Good afternoon, everybody, and welcome to the first Mtech Access COVID-19 weekly update. I'm Tom Clarke. I'm one of the directors of the NHS Insights and Interaction team at Mtech Access. And it's a privilege to have you all joining us today with our two NHS experts here. So just a bit of background, why are we here, I suppose? What are we doing? We, in the work that we do on a daily basis working with the NHS, are acutely aware of the pace of change that's happening at the moment. Huge amounts of things going on that probably many people never expected to change in the NHS. Lots of things that people hoped would change in the NHS. And it's a time of unprecedented transformation, I suppose. Something we're very involved with. We're also conscious that a lot of our colleagues from industry are at a time when they're unable to engage with the NHS, obviously grounded, stuck at home, doing a lot of desk work, but keen to understand what's really going on out there in the world. So we feel a bit of a responsibility, having relationships on both sides, to try and join the dots a little bit and help our clients stay in touch with what's going on, so that when they're able to get out there again, there hasn't been a big lag in momentum. And also from the NHS perspective, obviously a lot of our clients are bringing new treatments and therapies to market, and in order to make sure that those are getting to patients when they need to, we want to make sure that there's no sort of gap in understanding between the NHS and industry when everyone's remobilized, as it were. So that's why we're here. We are going to be doing an update every weekly, because of the speed of change. We're going to be calling on our NHS faculty members, two of whom we've got with us today. Our faculty work in a whole range of roles across the NHS, so every week we're going to have two different perspectives from across the NHS on what's going on. So over the course of the next few weeks, months, however long this might all go on, we'll give a really good breadth of understanding of how COVID's impacting on the NHS. Hopefully, as a result, if you're joining us regularly, you'll get a real good depth of understanding of everything that's changing, and you'll be well equipped to have the right conversations at the time that you can get back to the NHS. So joining us today, we've got Mike Proctor, who is the former Chief Executive of York Hospitals Foundation Trust and interim COO of the North Cumbria Integrated Care Partnership, and Hilary Snowdon, who's the management lead of two primary care networks in the North East. And they're going to be sharing some of their recent experiences and thoughts around everything that's going on at the moment. So enough of me. Let's have a chat with our experts. So firstly, coming to you, Hilary, can you just give us a few minutes on what you've seen happening in the NHS over the last few weeks in sort of the primary care world?
Hi, everybody. Yeah, certainly monumental change over the last 4 weeks. I don't think anybody, probably at the beginning of March, would have envisaged primary care working at scale as it is now. And I think it's a real defining moment for primary care networks and federations. I think certainly I've seen, you know how in families you have sort of like relations you don't speak to, but you're not quite sure why, because something's happened 20 years ago, but nobody can remember exactly what, but you still don't speak to them. In a similar way as primary care, or the elements of primary care, a bit like that, and suddenly what had been an issue that nobody could think of why they didn't want to work together, all that's disappeared. And suddenly we have people working together that probably used a lot of excuses in terms of the structures that are in the NHS, like IT. We can't possibly work with you because we've got a different clinical system. That has just completely disappeared. And practices, I think, for the first time, are really not just looking at them as autonomous individual practices, but that they have a collective responsibility for the wider population. And I think from our perspective in West Northumberland, that might not have happened without PCNs being established, and the fact that we've spent the last 10 months or so really working at relations and working better together, and that has really enabled and facilitate what we're having to go through now. And I think a couple of changes. I mean, there's been a 180-degree change in the use of technology. In the probably 4 weeks ago, people saw primary care as very much a face-to-face service. That isn't the norm any longer. And that's created challenges, hugely different ways of working for people. So that there's those aspects. I think also an appreciation that one size does not fit all, and I think there's still a tension between what's coming down nationally and the expectation that that will work regardless of where you are in the country. So the relationships that you have with your clinical commissioning group are really key at the moment, in the sense that some of them are assuming that whatever the centre's saying, that is what has to be implemented locally, whereas others are being very pragmatic and saying what's needed on a local level. So, for example, where I am in West Northumberland, we've got several hot sites being developed, all slightly different because of the rurality and what works for different practices. And I think the only other thing I'd probably say in terms of, at the moment, this key thing is that good clinical leadership is absolutely critical. And I think those relationships that clinical leaders have really worked at over the last few months are absolutely critical in terms of getting people on board, people being seen as credible leaders, and it's not just managers saying that you've got to do X, Y, Z.
Brilliant. Thank you, Hilary. And so, similar question to you, Mike. What have you seen in the last few weeks in the NHS?
I've seen some extraordinary things that I thought I'd never see, actually, to be honest. I'll try and give you a sort of a perspective from a single organisation, because people talk about the numbers, and I just thought it might be useful just to talk a little bit about the organisation I've just been working with as Chief Operating Officer, which I went over. I did 4.5 months over there, and troubled organisation, to be honest. It's so really small, so it's only got 550 beds, 2 sites, 2 hospitals that are 40 miles apart. Really struggling in terms of capacity, so working on 98% bed occupancy constantly. 25% of the beds in both hospitals were taken up by patients with a length of stay of more than 21 days, based on the sort of difficulties of services outside hospital. It was the norm every day, actually, to run out of beds and come into the hospital to have 15 or 20 patients in the ED department just waiting for somebody else to be discharged so that they could move up to a bed. And some of those patients were in 12, 15, 18, sometimes 24 hours in the emergency department. So a really troubled organisation. An emergency department that was built to sort of look after a maximum of 30 people, regularly having 60 people in that department. So this is pre-COVID, really troubled. I had a sort of, I talked to Tom about this, I had a sort of seminal moment on the sort of 9th of March, when I came into work, and our Deputy Chief Executive, who was a GP, public health doctor, enormous experience working for Médecins Sans Frontières abroad, looking at sort of Ebola, worked in real crisis points, and he'd been localizing and looking at the stuff that Imperial had been putting out in terms of the numbers, and he'd made it relevant to what was happening in North Cumbria. And the numbers he came out with, my sort of jaw hit the floor, really, because what he's talked about is that what we'd learned from sort of China and other places, that once COVID hits, then 80% of people that are infected by it can self-care. about 14% require hospital admission, 5% require ICU, and 1% die. You can look at the unmitigated curve. People talk about the peak of the curve. So what would happen if we did nothing? And the government worked on scenarios, and the Imperial worked on scenarios going from 70% of the population being affected down to sort of 1% of the population being affected. I'm not going to give you the numbers on 70% because they are unbelievable. Well, they are believable. But if the population of North Cumbria, 20% of people were infected, the attack rate was 20%, then that would mean that 60,000 people were infected in the North Cumbria population. It's a population of 300,000. And 8,400 people would require hospital admission. And 3,000 people would require intensive care. I have 12 beds. 12 beds. And the way that the infection would work would be that 20% of people that were going to be infected would be affected. 20% would be in 1 week, on week 10. And weeks 9 and 11, there'd be 15% of the population either side of that. So, 50% of the population over a 3-week period, which would mean 1,500 people in a 3-week period require critical care beds. So, it's just mind-blowingly frightening in terms of what was happening, which explains the government response, and it explains some of the local response. I was asked, in order to prepare, Mike, we need 150 beds by Friday. And I thought they were having a laugh, given the circumstances that we were looking at, and we were at 98% occupancy. And some amazing things have happened, because based on that, as Hilary's talked about, the entire clinical community came together. And some of the things that we've been wanting to implement and sort out for years, particularly around social care and moving patients on, those have been mandated by the government. And I'll tell you now, so North Cumbria is still coping. So North Cumbria, the last time I spoke to them, had 130 COVID-19 positive patients in hospital requiring care. And they had got about 20 people in critical care. So we've doubled and tripled the ITU capacity, and we're managing with that at the moment, because obviously the government's actions that have taken place in terms of social isolation and all those things are absolutely, instead of having a huge peak, we're creating a plateau. How long that plateau is going to go on, I really don't know, and how we get out of it is a question that's frequently asked at the government at the moment, isn't it? And there are dangers of second and third waves once we relax the measures that we've taken. But it's been a fantastic response. When all this was happening in China, and it came on the news that the Chinese had opened a 1,000-bed hospital, we all thought, well, that chance of us ever achieving that, until it came our way. And what have we done? We've opened a 4,000-bed hospital, and we're opening multi-sites all over the country. And I would not have thought that that was possible, but it's been proved to be possible. And we'll come on to talk about in a second, or in a few minutes, about what we want to keep. But partnership working, as Hilary's identified, we've talked through integrated care systems and all those types of things about people working as partners. The relationship side of that has accelerated hugely. There's going to be some golden nuggets in this. This is a tragedy for obviously for people that are going to lose family members and are going to be ill themselves. It's really, really difficult. But there's going to be some opportunities that arise out of this that the health and social care system have got to grab hold of and keep, because there are some great things that have been happening, which I'm enormously grateful for. But it's been fantastic being part of it, actually. And I've never seen morale as high as it is at the moment. There are obviously people are worried about PPE and all sorts of things, but everybody is just absolutely working together. Long may it last.
Brilliant. Thank you, Mike. So, I mean, obviously, there's huge amount that's changing at every level of the NHS, right, from policy levels up to down to the front line. So, Hilary, just thinking about within primary care and everything that's been changing, and obviously lots of that is very nitty-gritty stuff around practicalities, and some of it is more strategic. Of the things that have changed, could you pick out a couple of the sort of the most striking things, and just comment a little bit on whether you expect the change to last or not?
I think certainly changes in terms of, I think, an appreciation of the need for well-being of your staff is become much more important, and I would like that to continue. So not just on the physical aspects, but linked to what Mike said about that morale, about really looking after your teams and your workforce. And that's not just about pay, but it's actually, I know several practices have got wobble rooms now. So when somebody is feeling a bit, they can go in that room and maybe do a bit of meditation, yoga. So I think the appreciation of well-being of your workforce and how to do that is absolutely key. The joint working, I think what we've got to do is prevent people going back into their silos. And I think that's right across the system. So not just about individual practices, but making sure that community nursing doesn't become isolated from practice nursing, that it actually becomes a nursing team. And it doesn't matter who's employing them or whatever. It's about actually the world hasn't fallen apart by the fact you've let your staff work with another organisation staff. We have 14 practices in our locality, and 12 of those are in a PCN, and 2 of the practices decided not to be part of PCN. When we were thinking about our response to COVID, the terminology we used was really important. We had to be really careful. So we were very specific in saying, this isn't a PCN meeting. This is a locality response meeting. And we had to make sure that we had those other 2 practices on board. And if somebody had said to me 5 weeks ago, you're going to have 29 people on a screen, on a Zoom, covering 14 practices, and they'll all behave perfectly, and everybody will put their hand up when they want to speak, and it'll be very productive, I would never have believed it. And somebody has fed back to our clinical director and said, because of those meetings and the fact they're now seeing everybody, they feel part of a bigger partner family. And that is a really powerful thing to say, and I would hate to lose that. I think the other thing is, although we've gone through a system where it's been all face-to-face to practically non-face-to-face, I wouldn't want to continue with that completely, because I think there is a need for face-to-face between GPs, and a lot of GPs have said they don't want to lose, because that's their job, and they would hate to lose that completely. But I think it's a real opportunity to not go back to everything being done face-to-face.
So do you think care delivery is going to change dramatically as a result of this?
I think so, and I would hope so, because I think there's an appreciation about people realizing that they can. There's an element of saying, actually, I can look after myself, and I don't have to, the default position being, let's go to the walk-in centre or let's go to the GP. I have a concern, though, in that there's a lot of people who are going to be quite ill from non-COVID things later on, and that's starting to come through now because people have sort of delayed, and we're just starting to see that increase now in primary care, saying put that off as long as possible. And we need a response, thinking how are we going to cope with that. That's another curve coming. And I think the only other thing I would like think in terms of going forward is performance management. We have done so much, and as Mike very eloquently described, the things we've achieved, that have been achieved over the last few weeks, has all been because you've let people do things and not be just sort of strangled by information governance, all those things. And the performance management needs to be an enabler. So we need to make sure that going forward, we identify what's enabled all these things to happen, and how do we ensure that that gets carried forward.
Brilliant, thank you. So Mike, coming to you, what else can you add about, what's really impacted you, and that piece about the lasting change? What do you see going forward?
Yeah, so lots of things really. I guess one of the things, one of my comments would be, I always used to talk to all my direct reports and instruct them never start a sentence with Mike Proctor said. All right, and I'm going to plead for that for this audience, but because one of the things that I've noticed is that CCGs have become irrelevant in this whole thing. The work that's delivering the action on this is provider driven, and whether that's providers in primary care, secondary care, in social care, it's providers that are doing this, and I can't see a role for CCGs in what we're currently doing. They're scratching around to find one, but I don't think they are able to do so. So it's just a comment related to that. And the other thing I just wanted to mention briefly was just to follow up what Hilary said about people with other conditions. One of the judgments about our success through COVID-19 is that in overall terms, we don't have an increase in avoidable mortality. And that's not just COVID-19, that's in cancer and all sorts of other things, because we could absolutely get completely focused on this, but illnesses still go on. And I know some cardiologists that are really concerned about some of their patients that might normally turn up to A&E that are avoiding doing that at the moment. So I think that's something that we need to sort of be mindful of. In terms of lasting change, I think the partnership stuff, I think, it's as Hilary said earlier, a lot of the ice has been broken, people are working together in a really positive way, trust has been developed and built up, people are valuing other parts of the system actually more than they ever had, and I think that's an important aspect of developing trust. Particularly massive changes around social care. So hospitals have been waiting rooms for patients before they go somewhere else. Acute hospitals as waiting rooms and wards full of people waiting for some other type of care to be provided. That's all gone. It's all gone at the moment. And I know that's because the government stuck loads of money in the system, but we're finding ways to actually move people out of hospital, which probably does them damage in any case. So long lengths of acute stay in acute hospital is detrimental to patients' good and independence. And we've cut through all that. So as soon as a patient we don't talk about medically fit for discharge anymore, we talk about patients being medically optimized. And then they're out within hours. They're out within hours. And there is, some real risk management taking hold. So, when loads of people that were on 4 times a day visits are being told that they can only have 2, so that other people can have 2 as well. And then families are being asked to sort of, to make good the difference. Some really interesting sort of changes around that, but it's getting people out of hospital where they don't need to be. Outpatients, it's the opposite end to what Hilary's been talking about sort of virtual consultations. For donkey's years, I've been trying to persuade consultants that they don't need to see everybody face to face, but they've always insisted that they need to put their hands on people, and there's other places that have been successful in avoiding doing that. All of a sudden, consultants don't want to see patients face to face, and actually patients don't want to be seen face to face either. And in a community like North Cumbria, where people are sometimes travelling 50 and 60 miles for a 5-minute follow-up appointment with a consultant, to be told, yeah, it sounds like you're fine, I'll see you again in 6 months' time, it's absolutely the wrong way to actually manage patients. And consultants can offer far better advice to a greater number of GPs and about a greater number of patients if we do it virtually. So I think that's one of the significant things. And I'm going to be a bit cheesy in terms of lasting change. The final one I want to talk about is that people are looking after each other in society. You know, increase, you know, awareness of your neighbour, an elderly relative or something like that, and people are looking out. The vast majority of people are looking out for each other. You know, these things always bring out the best in people, and for a small proportion, it brings out the worst in some people as well. But for the vast majority of the population, there's a greater sense of society and community, and I hope that doesn't disappear, because that's really important as we go forward.
Brilliant, thank you. And we've got a couple of minutes left. So something that's sort of come out for both of you there is a bit around, you know, changing priorities and what have you. So just as a final word, I wonder if each of you could just give a sentence or two on, in 6 months' time or whenever the NHS is starting to get back to normal, how do you think they'll start to deal with the backlog and those sort of forgotten patients that are missing out at the moment?
I think it's about redefining a new normal. When we come out the other side of this, it's not going to go back. And part of that normal is going to be, you know, how do we sort of like look after this group of people with comorbidities in a much more patient-centered, focused way. And I mean that in terms of everybody working together, remove the silos, and also I think in terms of there's going to be a huge push on mental health as well. If we go into recession now, then actually we've got another huge number of cohorts of people who are going to require a lot of assistance and support. So I think we need to redefine what normal primary care is, what normal health care is, and what the expectations are. I think we really have to redefine expectations from ourselves as patients, our expectations of each other, and I think our expectations, government expectations of the health system as well.
Brilliant, thank you. And same question to you, Mike.
Yeah, we're going to have a huge backlog of work to do. I see the NHS having to focus on urgent and emergency work, for a good period after this. So yeah. What that means for some of the other elective work that we do, you know, the quality of life stuff, you know, I suspect that the private sector is going to play a big part in trying to get us back on track with some of those things. But depending on how long things go on for, depending what deterioration we've seen in performance target, depends whether there's a less emphasis on delivery of actually performance targets per se, and that we have a different opportunity to actually look at health outcomes as our drivers, rather than specific measuring specific parts of a patient pathway which do nothing for actually system working. So you know, nobody knows where it's going to end up, but I think there's going to be a sort of a difference in terms of workload that the NHS has to undertake.
Brilliant, thank you both. And I suppose one question in my mind, a one-word answer to see us through to Easter. Maybe it's a small topic to address. Do you think this could be the start of truly integrated care? One-word answer, Hilary.
Hopefully.
Mike?
I'm going to be optimistic. I'm going to say yes. I think it is.
Brilliant. Well, thank you both very much, and thank you to everyone that's been watching and listening. Hopefully that was as insightful for you as it was for me. That was sort of the organisational view, I suppose, of COVID. Over the next couple of weeks, we're going to be inviting guests to look from more clinical perspectives and looking at kind of the finance and commissioning elements and how that side of things has changed as well. So we're going to be doing these regularly now, every Friday at 2 p.m. This week was a slight exception for Easter. Hopefully you'll join us again. If you've got any questions as a follow-up from this, please submit them via nhsinsights@mtechaccess.co.uk, and feel free to direct colleagues to this, and the recording is going to be available after the event for anyone that has missed out. So thanks for joining us, and hopefully we'll see you next time.
Thank you.
Thank you.